Acute renal failure. Definition: it's a clinical syndrome characterized by rapid deterioration of renal function with or without oliguria. It's usually reversible with treatment of the cause. Patients with acute renal failure may have normal urine volume, and rapid I mean days to weeks. Synonyms: acute kidney injury, AKI. Etiology: 3 times 3, pre-renal, renal, and post-renal. Pre-renal: decreased renal perfusion, 80% of the cases, hypovolemia, hemorrhage, dehydration, burns, cardiogenic shock, decreasing cardiac output, renal artery stenosis, and hepatorenal syndrome. Renal: intrinsic, 10% of the cases, tubular, acute tubular necrosis, which is the most common intrinsic cause, acute interstitial nephritis, acute papillary necrosis from sickle cell anemia and diabetes mellitus, glomerular, rapidly progressive glomerular nephritis, lupus nephritis, renal vessels, malignant hypertension, PAN, DIC, thromboembolism, scleroderma. Post-renal, urinary outflow obstruction, 10% of the cases, bilateral ureteric obstruction, or unilateral ureteric obstruction with contralateral non-functioning kidney, obstruction of bladder and urethra. Acute tubular necrosis. Causes: ischemic and toxic. Ischemic: prolonged pre-renal cause for acute renal failure leading to tubular ischemia and necrosis. Toxic: bilirubin, hemoglobin, myoglobin, NSAIDs, radiocontrast dye, heavy metals such as arsenic and mercury, antibiotics, aminoglycosides, and amphotericin B. Pathophysiology: 3 stages: oliguric phase, diuretic phase, and post-diuretic phase. Oliguric phase: it lasts for few hours to weeks. Oliguria: decreased urine output less than 400 cc per day due to obstruction of tubules by epithelial casts, afferent vasoconstriction due to excess renin activation, and back leak of tubular fluid to renal interstitium. Decreased sodium dilutional hyponatremia, hyperkalemia, increased in phosphorus, calcium decreased or still normal, hydrogen ions and urea and creatinine are increased. Disturbances in calcium phosphorus renal anemia are less prominent than chronic renal failure. Diuretic phase: polyuria in this phase due to partial recovery of the tubules. And by partial recovery, I mean that the anatomy is corrected, no obstruction, no back leak, but the physiology is not restored because the kidney tubules are still unable to concentrate urine. Urine output increases up to 10 liters per day, but it may take several days before the creatinine starts to drop due to persistent afferent vasoconstriction in the early diuretic phase. Dehydration and hypokalemia may occur. Post-diuretic phase, convalescent phase, it may take weeks to months. There is complete recovery with improvement of the general health and normalization of the chemistry. Clinical picture: oliguric phase, it lasts for a few hours to weeks. Oliguria: decreased urine output less than 400 cc per day. Manifestations of hypervolemia, hypertension, headache, congested neck vein, pulmonary edema, and lower limb edema. Manifestations of hyponatremia, convulsions, confusion, and coma. Manifestations of hyperkalemia: skeletal muscle weakness, flaccid paralysis, areflexia, smooth muscle, intestinal colic, nausea, vomiting, cardiac muscle, arrhythmia up to cardiac arrest, and ECG changes. The ECG changes are tall, peaked T waves. This is the earliest sign of hyperkalemia. If potassium level is more than 6.5 milliequivalent per liter, wide QRX complex and prolonged PR interval, severe conduction delay when potassium level is more than 7.5 milliequilibrium per liter, loss of P waves, progressive paralysis of the atria. And it's important to know that absence of P waves doesn't mean sinus arrest, because the SA node can function without causing atrial contraction, but it can cause ventricular contraction. Any kind of conduction block, sine wave, ventricular fibrillation, asystole, if potassium level is more than 12 milliequivalent per liter. Sine wave means fusion of QRX with T wave and absent P wave. Suspect hyperkalemia in patient with renal failure, hemodialysis, taking any combination of ACE inhibitors, potassium-sparing diuretics, and potassium supplements, presenting with new bradyarrhythmia or AV block. Then, manifestations of acidosis, rapid deep respiration, manifestations of uremia, anorexia, nausea and vomiting, astraxis, pericarditis, bleeding, convulsions, confusion, coma, death. Causes of death are pulmonary edema, cerebral stroke, bleeding, and infections. Diuretic phase, dehydration and hypokalemia, post-diuretic phase, convalescent phase, improvement of general conditions, and it may take for weeks to months. We need to know that causes of increased respiratory rate in acute renal failure are compensation of metabolic acidosis with pulmonary edema. In acute renal failure, remember that there are 3 no's: no bone manifestations, no endocrinal manifestations, no or mild anemia. Investigations aim to prove condition, to assess severity, and to search for the cause. Urine examination, blood examination, renal function test, ultrasound, and investigations for the cause. Investigations for the cause: retrograde pyelography and angiography, plain film of the abdomen to detect stones, ultrasound shows normal diameter, renal function test impaired azotemia due to increased urea and creatinine with decreased creatinine clearance, blood examination such as pathophysiology, decreased sodium, dilutional hyponatremia, hyperkalemia, increased phosphorus, increased hydrogen ion, urea, and creatinine, but disturbances are less prominent than chronic renal failure. Then we have urine examination. It shows oliguria less than 400 cc per day, and urea is characteristic of post-renal causes. Specific gravity is fixed, 10-10. Casts, it shows pigmented casts in myglobinuria, white cell cast in acute interstitial nephritis, and muddy brown granular cast in acute tubular necrosis. Urine sodium to differentiate pre-renal causes from acute tubular necrosis. Pre-renal causes, urine sodium is less than 20 milliequilibrium per liter, while in acute tubular necrosis, urine sodium is more than 40 milliequilibrium per liter. Fractional excretion of sodium, it's urine sodium over serum sodium divided by urine creatinine over serum creatinine times 100. Pre-renal causes show less than 1%, while acute tubular necrosis show more than 2%. Fractional excretion of other substances can be measured to determine renal clearance, such as urea, and this is used in patients undergoing diuretic therapy because they induce natriuresis, so urinary sodium concentration and fractional excretion of sodium may be higher in patients receiving diuretics in spite of pre-renal pathology. Urinary osmolality is more than 500 milliosmoliter per kilogram, and this is highly suggestive of pre-renal azotemia, while in acute tubular necrosis there is damage in loop of Henle, impairing ability of the kidney to generate high interstitial osmolality, so it will be less than 350 milliosmoliter per kilogram. So if we're going to compare between pre-renal and renal regarding the investigations of urine examination, urine sodium in pre-renal less than 20 milliequilibrium per liter, while in renal more than 40 milliequilibrium per liter. Fractional excretion of sodium is less than 1% in pre-renal, more than 2% in renal causes. Urine over creatinine is more than 20 in pre-renal, less than 10 in renal. Urine osmolality is more than 500 in pre-renal and less than 350 in renal. Then we're gonna talk about REFL classification. REFL: R, risk; I, injury; F, failure; L, loss of kidney function; E, end-stage kidney disease. We say risk if serum creatinine is increased by 1.5 times, or GFR is decreased more than 25%, and the urine output would be less than 0.5 milli per kilo per hour each 6 hours. Injury if serum creatinine is 2 times or the GFR decreased by more than 50%, urine output would be less than 0.5 milli per kilo per hour in 12 hours. Failure if serum creatinine increased by 3 times or GFR decreased more than 75%, or if baseline of serum creatinine is 4 or more than 4 milligram per deciliter with acute increase by 0.5 milligram per deciliter, by more than 0.5 milligram per deciliter, by more than 0.5 milligram per deciliter. And the urine output would be less than 0.3 milli per kilo per hour in 24 hours, or anuria within 12 hours. L. Loss of kidney function, persistent acute renal failure for more than 4 weeks, end-stage kidney disease, persistent renal failure for more than 3 months. Treatment: prophylactic, curative, and conservative. Prophylactic treatment: avoid nephrotoxic drugs as possible. Avoid radiocontrast dye in diabetes mellitus. Curative treatment: urinary catheter, central venous catheter, immediate volume infusion, diuretics, and dopamine. Urinary catheter to assess urine volume and exclude post-renal causes. Central venous catheter to assess blood volume. Immediate volume infusion to prevent acute tubular necrosis. Diuretics, but there is a little or no chance in increasing urine output. Dopamine, renal dose 2 mg per kilo per minute, leading to renal vasodilatation, but the side effects are bowel ischemia and decrease in the TSH. Conservative treatment: diet, decrease water, sodium, potassium, protein, up to 40 gram per day. Drugs, just symptomatic treatment, 7H and 3A. Hypervolemia, Lasix. Hypertension, ACE inhibitors, beta blockers, calcium channel blockers, diuretics. Heart failure, diureters, digitalis, diuretics. Hyperkalemia with the mnemonic acid. A. Acidosis correction by sodium bicarbonate. C. Calcium gluconate, slowly infusion. I. Insulin and glucose for intracellular shift of potassium. D. Dialysis. Hyperphosphatemia, phosphate binder, aluminum hydroxide or calcium carbonate. Hypocalcemia, calcium gluconate, hydrogen ion, sodium bicarbonate. Anemia, erythropoietin, 4,000 micro, 2 times per week, and packed RBCs with iron. Antibiotics for infections. Anorexia, nausea and vomiting, domperidone or metylium. Renal replacement therapy, dialysis and renal transplant. Indications of dialysis, whether clinical or lab. Clinical: acute pulmonary edema, pericarditis, persistent diarrhea, preoperative, coma, convulsion, deterioration of general health. Lab: if urea is more than 200 mg per deciliter, the normal is from 20 to 40 mg per deciliter, or if creatinine is more than 8 mg per deciliter or more than 7 in diabetics, the normal is from 0.7 to 1.2 mg per deciliter. Potassium, if more than 7 millicubium per liter, the normal is from 3.5 to 5.5 millicubium per liter. Bicarbonate, if less than 14 millicubium per liter or pH less than 7.2. Hypercatabolic renal failure, creatinine increases by more than 1 milligram per day, or potassium increases by more than 0.8 milliequilibrium per day. Treatment of diuretic phase: high salt and high potassium, adequate fluid to avoid dehydration. Indications of renal biopsy in case of acute renal failure, whether unclear etiology or if there is no recovery after 3 to 4 weeks, because severe cases may be associated with cortical necrosis, and this has poor prognosis and the patient is converted to chronic dialysis program. Tubulointerstitial nephritis is defined as injury initially involving whether tubules or interstitium of the kidney. They are intimately related, and that's why injury in one of them invariably results in damage to the other. Acute tubulointerstitial nephritis, the etiology: 4I, iatrogenic, 70% of the cases, drug-induced hypersensitivity nephritis. NSAIDs: allopurinol, thiazide. Antibiotics: methicillin, sulfonamides, cephalosporins, ciprofloxacin, and rifampicin. Others: allopurinol, thiazides, and NSAIDs. Infections: viral, hantavirus, Epstein-Barr virus, bacteria, streptococci, legionella, mycoplasma. Immune: SLE, Sjogren syndrome, sarcoidosis, Wegener's granulomatosis, transplant rejection. Idiopathic, rare, it can be associated with anterior uveitis. Clinical picture: oliguric or non-oliguric acute renal failure. Clinical picture of the cause: systemic manifestations of hypersensitivity such as fever, arthralgia, and skin rash. Investigations: blood, eosinophilia, raised immunoglobulin E. Renal biopsy: interstitial cellular infiltrate, including eosinophils, and finally urine analysis, eosinophiluria. Insights can cause glomerular minimal change lesion in addition to tubular interstitial nephritis presenting as nephrotic syndrome. Treatment: withdrawal of the causative drug. Most cases will improve without further treatment. Short course of steroid, prednisolone, 60 mg per day for 10 to 14 days. Methylprednisolone, 1 gram per day for 3 days. Duration of steroids shouldn't exceed 2 to 4 weeks. Conservative treatment of acute renal failure. Dialysis may be indicated. Chronic tubular interstitial nephritis. Drugs: all causes of acute tubular interstitial nephritis, plus cyclosporin and cisplatin, lithium. Toxins: lead, cadmium, irradiation. Chronic infections: chronic pyelonephritis. Diseases: multiple myeloma, sickle cell anemia, diabetic and hypertensive patients. SLE, gut postural syndrome, sarcoidosis, Wegener's granulomatosis. Metabolic: hypercalcemia, hypokalemia, hyperuricemia. Reflux nephropathy, presenting in childhood by repeated infections, loin pain in voiding, leading to chronic renal failure due to renal scars, infection, and focal glomerulosclerosis. Clinical picture of the cause with manifestations of chronic renal failure, and treatment of the cause. Chronic renal failure and nephrogenic diabetes insipidus may be associated. Analgesic nephropathy, chronic interstitial nephropathy due to chronic consumption of large amount of analgesics. NSAIDs are now the most common causative agents, especially since withdrawal of phenytoin from pharmaceutical market. Clinical picture: twice in women and men, common in middle age. Clinical presentation of chronic renal failure. Clinical manifestations of renal papillary necrosis, UTI, hematuria, urinary tract obstruction due to sloughing of renal papilla. And this concludes acute kidney injury.